Good evening, everyone. I'm Dr. Girish Agrawal, and today I'm going to moderate a session on hydatid lung disease. At the outset, I'd like to thank Dr. N.H. Krishna, founder CCI, Dr. Ashish Dubey, President CCI, Dr. Anil Maske, Secretary CCI, and also I'd like to welcome our esteemed faculty, Dr. Sanjay Sahay, who is a pulmonologist in Ghaziabad, Dr. Nilanjan Umesh, who is a pulmonologist in Kochi, Dr. Arun, who is a pulmonologist in Chennai, Dr. Soumitra Shah, who is a transplant pulmonologist in Chennai, and Dr. Mohan Venkatesh, who is a CTV surgeon in Gurugram. So the roadmap to the tour, today's discussion will be, I'll be briefing on the case scenario of hydatid cyst and a small introduction to the hydatid cyst. My talk will be followed by a talk from Dr. Mohan Venkatesh on the advanced surgical approach of for treating the patient of hydatid. And then we'll open the session for question and answer with the panelists. And after panel discussion, the house will be open to our esteemed audience. I will also like to welcome our audience for joining this session. So, hydatid lung disease. This is a case scenario of a young male who presented with low-grade intermittent fever for a year, has a cough with expectoration, breathlessness on exertion, which was increasing in nature, and outside when he came to us before, he was started on APP, for which he took it for 6 months. We reviewed his serial X-ray, and this was the X-ray which was showing some hyperlucent area on the right side and some opacities on the left side. This was the X-ray on presentation. We can see that there is a walled off cystic lesion with something floating on the base and some infiltration on the left side of the X-ray. This was the old CT. Here we can see there is a well-defined cystic lesion with air fluid level or something floating along with the pleural effusion and infiltration on the left side. And this was the X-ray on presentation. Definitely there is increased involvement of the bilateral lung field. This was the CT on presentation. That cyst has been now filled up completely, and it looks more like a mass-like opacity which is present in the bilateral lung field with some areas of cavitating nodule or air crescent sign. This is just a demonstration of how this water lily sign, which we'll be discussing later, appears on the CT scan. We did the bronch, and here we saw a whitish membrane which was coming from the left side of the lung. And no doubt the diagnosis was hydatid cyst, bilateral hydatid cyst, and patient started improving after medical management. So, hydatid cyst is caused by a tapeworm called Echinococcus. Basically, there are 4 species. Mostly granulus and alveolaris are known to cause the human infection. Granulosus causes cystic echinococcus, and alveolaris causes alveolar echinococcus. Our main focus on today's topic will be on granulus or cystic echinococcus because it is what which affect the liver, lung, and multisystems. Alveolaris is predominantly in the liver, and extrahepatic is just in about 1% of the case. A brief on the life cycle. So there are basically 2 hosts to the echinococcus. One is a definitive, another one is an intermediate. Dog and other canids becomes a definitive host, and sheep, goats, or swine as the intermediate host. After ingestion of the fecal material of the dog or infected soil or water, the embryonated egg in the feces, they are passed on to the ships or the intermediate host, where they transform from oncospheres to the hydatid cyst. And when the fecal material or when a mass of the slaughtered sheep, goat, or swine is being eaten by God, this hydatid cyst is ingested by the dog went to the intestine to form the proctoclosis and scolus, and again the adult intestine. It becomes an adult in the small intestine and thus completing a cycle. At the point where the intermediate host get infected is the same point where the human can get infected with embryonated egg in the soiled feces or the soiled water infected with the echinococcus. Its life cycle is basically of 30 to 80 days. Oncosphere, or also known as the embryos, and hydatid cyst is also known as metacystodes. As I told you, we will not focus much on the multilocularies, but one thing which is important is it's definitely host besides stocks of POX, or the major definite host, and intermediate host is a small rodents. One thing which I'd like to mention is a cyst without protospolosis or sterile, sorry, and in human alveolar hydatid, there is no protospolosis. Just a brief on how the cyst appears. It has got a three layer. The outermost layer, which is formed by the reaction of the human tissue, is called the paracyst. It has a laminated layer called exocyst, and inner germinal layer, which is called an endocyst. From the germinal layer, you can have multiple small cysts. If they remain attached to the germinal layer, they are called the broad capsules. And if they get detached from the germinal layer, they are called daughter cysts. Now, presence or absence of daughter cyst is important because the management changes in the presence or absence of daughter cyst. As I told you, there's an endocyst, exocyst, and the paracyst, and the broad capsules. And you can see that in Canococcus multilocularis, or which calls the alveolar loculus, there is no paracyst, as a result of which the daughter cyst, they are proliferated within the hydatid cyst and also exogenously into the infiltrative host tissue. With this, I'll rest my presentation, and I'd like to invite Dr. Mohan Venkatesh to highlight on the advanced surgical approach to hydatid cyst. Thank you. Dr. Mohan Venkatesh, please. You can stop it, Suraj.
A very good evening to all of you. First of all, I should congratulate the CCI team for relentlessly conducting such high quality webinars for the last 2 to 3 years. And thank you so much, the team CCI, for giving me this great opportunity. So the topic of my presentation is the surgical treatment for pulmonary hydatid cysts. Broadly, the treatment of pulmonary hydatid cysts is either with surgery along with chemotherapy, which includes the antihelminthic drugs. Although the surgery is the most effective and definitive treatment strategy in the management of pulmonary hydatid cysts, in few cases where there is disseminated disease and the patients are actually unfit for any kind of surgical intervention, medical therapy only also plays a very important role. If we see the factors that actually affect the treatment plan in the hydatid disease of the lung, there are several factors. The most common factor that we see are what is the size of the cyst? Is it small? Is it big? What is the number of the cyst? Is it on the right side there are 2, 3, multiple, or they are bilateral, or sometimes we have seen patients with lung hydatid and also with the liver hydatid, and we have seen also patients with bilateral hydatids with mediastinal or pericardial hydatid cysts. In addition to that, we have to also see the potential complications that are related to the cyst, like either into the intrabronchial rupture or leading to the consolidation of the lung, or sometimes they rupture into the pleura, causing the dissemination inside the pleura. And once then there is a possibility that these are actually affected by the associated bacterial and fungal infections. And most important, in addition to all these factors, we have to see the general condition of the patient also to decide about the surgical treatment. The principles of surgical therapy are mainly 3. The first one is the surgery is to eradicate the parasite by removing the endocyst of the parasite. And we have to be very, very cautious not to spill the contents of the cyst within the pleural cavity during the surgery. After that, we have to manage somehow the pericystic space. Once the mass effect, the cyst has been removed, the space that is left out, we have to manage that cyst. And third, we have to preserve the lung tissue as far as possible, because this is a benign kind of lung disease. we have to do a lung preserving surgery in most of the situations. These three principles will contribute to the principles of the surgical therapy in the management of hydatid disease. Once we actually evaluate a patient for surgery, we have to take these four things into consideration. First of all, we have to select the art of the surgery. Suppose once we have a patient with a single organ involvement, always we have to search for multi-organ involvement. If we have a lung hydatid cyst, we have also to search for liver hydatid, any intra-abdominal hydatid. We have seen patients where bilateral lungs are involved, pericardium is involved, liver has multiple cysts, and also the patient is having a hydatid cyst in the kidney or the suprarenal gland. And the other thing that we have to see is what type of skin incision, what is the approach that we have to do depending on the organ of involvement, organs that are involved. In addition, the most important thing is what is the timing of surgery in relation to the use of the medication, that anti-helminthic medications. We have to start after surgery, we have to start before surgery, or how many days we have to continue the medications after the surgery. So these are also things which we have to decide before going for the surgical intervention. And also the most important thing is what is the surgical approach that we are going to do. Are we going to do the surgery by thoracotomy, VATS, robotic, sternotomy, the thoracotomy with a transdiaphragmatic approach to the abdomen? So we have to see, depending on the extent of the disease, we have to plan this thing. So once you have ruled out the multi-organ involvement, sometimes we have patients with lung and liver hydatid cysts. The priority goes for lung. So we have to, in such situations, we have to operate the lungs first, and then we can address the liver in the same sitting, or we can do it sequentially also. In case of pericardial and lung involvement of hydatid disease, in the same sitting by either sternotomy or clamshell thoracotomy, you can treat both the diseases. And the third thing, we often see such conditions where there is bilateral hydatid lung cyst. The rule that we follow is that the Verser side should be operated first. The lungs which are going to rupture, which are very tense, which are going to rupture, so those side we have to operate first, and then in the same sitting or sequentially we can operate the opposite side. And then selection of the type of the skin incision. There are several methods or approaches that we can go. It can be a mini thoracotomy, bilateral thoracotomy, sternotomy, thoracotomy and laparotomy in cases of liver involvement, thoracotomy and transdiaphragmatic approach in cases where there is the liver which is involving the superior most part of the liver with the involvement of the diaphragm. And then now we are doing many of the cases by video assisted thoracoscopic method. Let's see this case where there is a right side very large hydatid cyst. We can give a small incision over the cyst, and we can empty the contents, and we can treat this disease surgically. So in such cases, we can get away with mini thoracotomy, or now we can go ahead with the video assisted thoracoscopic surgery. And let's see the second case. In this case, we have a very, very large cystic disease in the right side of the chest, almost occupying more than 2/3 of the chest cavity. In such cases, giving small incisions doesn't help much during the surgery. So we have to go with the standard thoracotomy. And let's see the another case scenario. We have bilateral large hydatid cyst. As I said earlier, we can go ahead with bilateral thoracotomy. In this, the left side looks much larger and more tensor than the right side. So we can go ahead with the left first and then go ahead with the right. So or sometimes you can go ahead with the sternotomy and you can approach both thoracic cavities in the one go. And sometimes nowadays we are doing a bilateral VATS, and which can be simultaneous or sequential. And then this is another case scenario. This is involvement of the superior most of the diaphragm with rupture of the cyst into the pleura. So in such cases, we have to use the right thoracotomy, and you can resect the diaphragm where the rupture has happened, and you can deal with the disease from the transdiaphragmatically also. Another case scenario, you have a lung cyst, and also you have very, very big hepatic cyst. You can go ahead with thoracotomy or laparotomy, or nowadays we can go ahead with video assisted thoracoscopic surgery or laparoscopy. So you can have seen, so depending on the different organs of involvement, our surgical plan is actually changing. In this case, you can have the lung cyst, we have mediastinal, you have hepatic cyst. So the priority, as I said, that goes to the chest first. So we have to deal with the chest, and followed by we have to deal with the liver cyst at later stage. So this is about the type of the skin incision. And the third important thing is what is the timing of surgery in relation to the medications. So the usual protocol that we follow is preoperatively, once you have diagnosed the patient is having hereditary disease, you give 7 to 10 days of therapy before the surgery, and then you subject the patient for the surgical intervention with the principles as I already mentioned. And once the surgery is over, the adjuvant therapy depends on the intraoperative findings. If the cyst is contained, there is no intraoperative spillage, you can give the albendazole therapy for next 1 month and you can stop. In case of intraoperative ruptured cyst or there is a intraoperative contamination of cyst contents, you can go ahead with 3 to 6 months of albendazole therapy. In cases where you are not able to remove the complete cyst, in such cases, you have to continue the antihelminthic therapy till radiologically there is no evidence of cyst within the body. And then the last and the most important thing is what is the intraoperative surgical approach. You can have various surgical approaches in our armamentarium. They can be conservative or radical. As I said, the lung preservation is the basic concept behind the surgical management. So all these conservative therapies are aimed at conserving the lung parenchyma. Whereas in radical disease, where we have to remove the lung parenchyma along with the cyst, where there is a complication associated with the lung cyst. So the conservative therapies includes, it can be enucleation, in which you actually take out the whole of the cyst in one go, that's called enucleation. And then pericystectomy, along with the endocyst, you also have to remove the pericyst, that is the inflammatory reaction of the organ towards the cyst cavity, you have to remove that also. Because this removal of the pericyst is also associated with a lot of postoperative complications like air leak, empyema formation. So in the present era, pericystectomy is not used. And then the third and most favorite of the many surgeons is the cystostomy and the capitonage. In cystostomy, you actually open the cyst cavity, you empty all the contents by ensuring that there is no spillage of the contents into the chest cavity, and then you manage the pericystic space by doing capitonage therapy, like you are actually closing the cavity like a book so that there is no residual space. And there are several variations of this method. One of it is Posadas method, where before capitonage, you actually close the multiple bronchopleural fistulas or bronchial openings, and then you do the capitonage. In some cases where there is a small peripheral kind of cyst or there are fissural cysts, you need not to actually do the capitonage. In such cases, you can do cystostomy and you can close the bronchial openings. And the last and the other method is a Figueroa technique, which is equivalent of Pear technique in liver hydatid cysts, where you actually don't do complete excision, you actually only do aspiration and then you manage the cyst. In present era, Figueroa technique is not being used because of the fear of spillage and the pleural contamination. This technique is not used by most of the surgeons. And then radical therapy, if it is localized to one segment, you do segmentectomy. If it is large, occupying more than 50% of the lobe space, and it is causing some the consolidation of the underlying lung, which is infective in nature, and then in such situations you have to go for lobectomy, and in very, very rare cases you have to go for pneumonectomy. So these are the various intraoperative approaches that we use for management of hydatid disease. So this is what I was saying about. This is the enucleation or Ugan's method. So this is a left-sided upper lobe disease. Once we cut the lung tissue, the cyst will appear like that. This is the whole of the endocyst. There is no rupture of the cyst. With the two forceps, we are actually holding the pericyst, and we ask the anesthetist to inflate the lung, and the whole of the endocyst can be delivered out enucleated like that. So this is the pericystic cavity. We can close the bronchial openings and we can close the chest in such cases. Second thing is the Barrett's or Pasodas method that I have mentioned, which includes the cystostomy. Contents are removed. The white structure that we are seeing is the pericyst, that is inflammatory reaction, and you do the capitonage. You can see on the right side picture, the capitonage actually causes the deformation of the lung tissue, which will causes the residual spaces in the parenchyma. That we have to be very clear when we are actually going with this method. Third thing is the cystostomy and the closure of the BPF alone. As I said, this is the case with the left lower lobe hydatid cyst. It is actually on the fissural surface, very close to the pulmonary artery. So we are not able to do a segmentectomy in this case. So that's why we chosen this method of cystostomy and closure of the BPF. So once we do the epidurolysis, we actually pack the whole of the chest cavity with betadine soaked sponges so that any spillage, minor spillage happens, so it acts as a squalicidal agent. So you can see all of the chest cavity has been packed with the betadine, and betadine has been instilled into the chest cavity. We give an incision over the cystostomy, over the cyst, and we insert a cannula into the cyst cavity. We inject the betadine. We keep it wait for 5 minutes, and then we extend the incision over the cyst. So these are all the germinal membranes, are also called endocysts, which are carefully removed not to contaminate the chest cavity. And once we remove the cystic contents, then we have to excise the excess of the residual cyst wall that is there, and then we have to check for the air leak, for any air leak that is actually happening from the wall of the cyst cavity. You can see here there are 2-3 openings from where the air is actually leaking. And at that stage, we have to take sutures to close those bronchopleural fistulae. And once we close the bronchopleural fistulae, then the first, and this is the second bronchopleural fistulae closure. And then after that, we actually check for the air leak. There is no air leak, and you can put it drain, and you can come out. The lung is completely expanded. So this is a method of dealing with the peripheral hydatid cyst. And the last one is segmentectomy, where actually one of the segment is completely involved. You can see the lung is very angry looking. It is involving the anterior vessel segment of the right lower lobe. So in such cases, what we do segmentectomy by serial firing of endoscopic linear cutter devices in multiple, so that the blood supply and the bronchial supply to the rest of the lung is actually maintained well, so that we can have adequate lung expansion at the end of the surgery. So this is the staple line, the cyst removed, and you can see the good lung expansion achieved at the end of the surgery. So these are the various surgical methods that we do. And in this case, the whole of the major part of the lower lobe is actually involved. So we had to do left lower lobectomy in this gentleman. So the conclusion of this presentation is that the surgery is a definitive therapy in the management of hydatid disease. The proper planning is the key for success in such cases. All the things that we have to see while dealing with surgical intervention has been mentioned earlier. And the treatment should be, as I said, it should be tailored to every patient needs, because all hydatid cysts are not same and all the patients are not same. So depending on the location, depending on the size, depending on the general condition of the patient, depending on the complications that are associated with the cyst, we have to tailor the treatment as per the situation. Thank you so much for giving this opportunity.
Thank you, Dr. Mohan, for an very sweet and nice talk on the surgical options of hydatid cyst. Now, I think we can start the panel discussion, and I do have few questions to you, Dr. Mohan, but I think we'll just wrap it for the first panel discussion with the clinical manifestation and everything, so that it becomes more clear how to approach rather than directly jumping into the complication of the treatment part. So I'll start with Dr. Arun Sampath. Sir, as you have seen the case which I presented, the patient presented very late. He almost took 6 months of antitubercular drug. And when he presented, he was already on finishing bilateral hydatid cyst. So what all clinical signs and symptoms do you think that probably was missed by the first hand physician, or we should look into it?
At the outset, I would like to thank our CCI for this wonderful opportunity for this forum discussion. Wonderful presentation, and yeah, I do agree. Most of the times they present very late. That's because of the inherent nature of the hydatid cyst. There is very slow growing, and if it is uncomplicated, most of the times it is an incidental finding. For example, the patient might be coming for some health checkup or a preoperative chest X-ray, or for some other reasons we tend to pick up something, some nodule or some mass or some cyst, and that time we start evaluating. Some patients, as you rightly showed, that they present with symptoms, but most of the times they are non-specific. There is no particular specific symptom for the hydatid cyst. It all depends upon what exactly complicating the cyst. If it is a rupture or a super infection, or it is just a compressive symptoms of a large cyst. So if it is usually around 40 to 50% in due course develop some rupture. Rupture also can be, it could be a contained rupture or it could be a complete rupture. That time the patient will have symptoms such as fever, cough, hemoptysis, some chest pain, even breathlessness. And if the rupture happens to the pleural cavity, they may present with a sudden anaphylactic reaction also. And on the other hand, if the cyst is so huge and they are presenting with their expansile compressive symptoms, the compression can be on the nearby mediastinal structures, the central chest pain can happen, or the nearby thoracic cavity where they may present with a pleuritic or even a chest wall pain. So most of the time the patient do present with so many non-specific symptoms. So by only clinical symptoms or some signs, we will not be able to exactly say the patient is having hydatid cyst. So it is, you have to keep, it is a differential diagnosis. If the particular patient history is having a close contact with the dogs or cattle such as slaughterhouse, or they are rearing the cattle, especially sheep or goats, and the radiology is showing a soft rounded opacity, then we need to proceed with further evaluation.
So as in this case, it was a ruptured cyst because we can see a water lily sign. There's a germinal layer which is protein, and it happens only with a degenerated or a ruptured cyst, right? And and eventually it led to a bilateral hydatid lung. So we have shown you the X-ray, we have shown you the CT scan. Do you think for confirmation or just biochemical marker or the biochemical parameter be helpful to diagnose hydatid?
So any parasitic infection, if you take the only one I can't say it is a biomarker. Lab investigation is sometimes they can have a eosinophilia, peripheral blood eosinophilia can happen, and it is also not specific for hydatid cyst, and it is also not present in all the cases. 25% of hydatid cyst patients. And see, we are talking about the lung hydatid alone, but sometimes they also have a hepatic hydatid. So in that case, they will have a transaminitis or even mild jaundice or even elevation of amylase. So if it is only a lung hydatid alone, eosinophilia can happen, and there is not a particular lab or a biomarker to say that this particular patient is having hydatid cyst. In your presentation, yes, the case, because of the the clinician should have the suspicion if the patient is not improving, or if the patient, the radiology is though having multiple nodules and consolidating findings, but if the patient is not improving, it's very common in India to misuse the ATT drugs for any radiological findings. That should not be there.
Any role of serology?
Yes, serology, of course. This is the one helminthic disease, if you take radiology and serology is the confirmatory diagnosis. It is not by any clinical or some parameters. It is usually by the serology which gives the the next level of confirmation if we have a strong suspicion of hydatid cyst. So we have ELISA for especially the immunoglobulin G, and I even checked with many laboratories because for this presentation, and now we usually have only for IgG for the hydatid fluid. And if you see in the literature or in the Western countries where there actually the incidence is more, especially in Mediterranean or the Central Asian countries or in the South American, where they also have other type of ELISA, and for example extended panel testings to the other antigens, especially like I can say the antigen 5 or the recombinant B antigen, and which actually is not available for our patients, is not easily accessible. So if you say the serology, yes, of course IgG ELISA is available for the hydatid cyst fluid, and the titer should be more than 1.2, and if it is more than 1.2 it is positive, if it is less than 0.8 it is negative, and if it is in between this range 0.9 to 1.1 you need to repeat the test after 2 weeks. But the serology test for the hepatic hydatid, it may be positive even up to 90%, but for lung hydatid, even if the positivity, the sensitivity will be around 60% alone. Still we miss 40% of cases. So again, it's a combination of radiology and
So
serology.
that brings to the next question. Yeah. So what if you are suspecting hydatid on history, on radiology, and you have a negative serology? It's an isolated lung hydatid. So if there is a negative serology, which we say that is hardly in the 60% of the pure lung hydatid where the ELISA can be positive. Now, how we should approach such cases?
Then
Means defining that there is a WHO scoring system based on the ultrasonography. There's a classification of the system. So, is radiology sufficient enough to diagnose hydatid if serology is negative, or we need both the evidence of serology and radio diagnosis, or does the bronchoscopic bar can add something to it?
see, yeah, actually, the radiology, if you see that the WHO working group for echinococcosis, the ultrasound classification is only for the hepatic hydatid cyst. Because if the cyst which we are talking about the lungs, if it is not adjacent to the periphery, the ultrasound of the lungs will definitely miss it. So there is no typical classification based on the ultrasonography for our lung cyst. So if we take it as like it is combined with the what to say, the X-ray, or we have to go to the CT chest, sometimes even the MRI, and we need to add on with the serology. And even then, if the suspicion is very high, but still if the serology is negative, because of the non-availability of the other tests. See, there are many other tests actually in literature, and actually it's available in US and Europe. Like even they are doing Western blot, immunoblot techniques, even they are doing multiplex PCR analysis. They are even doing indirect hemagglutination assays. They are doing even serum antigen detection assays, which are not widely available in India. So there is a algorithm especially given if there is a positive radiology but negative serology, then we need to proceed to all these tests like one by one, going for the extended panel testing. Then even that is negative, then we need to go for the immunoblot, Western blot techniques. If in India, if we have strong suspicion, radiology is positive but serology is negative, then we have only left with other option called like fine needle aspiration, and then we can do a microscopic analysis, which carries risk, but still that is the next step we can do.
Right. So with the fine needle aspiration, if there is a spillage, we all know it can lead to a severe anaphylaxis, and that brings us to the next question for this session to Dr. Sanjay Sahay. Dr. Sanjay, anaphylaxis has got a peculiar definition, and there are few symptoms which are defined for anaphylaxis, but did not need to be presence of hypotension or so, right? So how, when will you suspect anaphylaxis in absence of hypotension.
So am I audible?
Yeah.
Hello? Okay.
Yeah, you're audible.
Okay. Good evening, everybody. Thank you very much to the CCI for giving me this opportunity to speak about the Hydatid cyst. Although it is
Dr. Sanjay, you are not visible. You can put on your
not
video.
visible.
Yeah.
I'm sharing it.
Yeah, he's visible.
Yeah.
Is it okay?
We can proceed. We are still not able to see. Let the technical team fix it. By the time we can give proceed with the answers.
Right.
I can see.
Yeah. Okay.
Okay.
Yeah. Yeah.
Okay. So anaphylaxis, as we know, it can occur in any patient, especially when we are dealing with the Hydatid cyst. It is most of the patients usually are asymptomatic, but it occurs when there is any spillage of the fluid inside the body, anywhere in the body. As you asked, without hypotension, yes, they can occur. Although hypotension and cardiac symptoms, they are more serious problems with that. Especially the presentation in cases of anaphylaxis is maybe mild due to presence of the skin involvement, maybe itching, some articular rashes, and some macropapillary rashes may be there. There may be angioedema. So skin when it starts from the skin, and after that maybe if the Hydatid cyst is present in the liver or in the lower side, maybe some dragging sensations will be there. Respiratory system involvement and cardiovascular system. This is the most important anaphylactic reactions, which is life-threatening also. So in cases when the respiratory tract is involved, as you know, there will be bronchospasm, there will be cough, and patient will have chest pain, chest discomfort, and also sometimes he end up in the cyanosis. Along with that, if cardiovascular system is involved, as you said, hypertension may be there, but sometimes if the immediate effect may have the cardiac arrest if it is not properly dealt with immediately. So apart from hypertension, other system involved are there, and if more than two systems are involved together, then it's a severe form of anaphylactic reaction that we suspect.
So you mean to say that even if there is no hypotension and two systems are involved, then it is classified as a severe anaphylaxis?
Yes, we can consider it as a severe.
Right. And how will you proceed with the management or rescuing the patient?
Yes, as soon as the patient we suspect there is a severe form of hypersensitivity, we put the patient over the bed, maybe in the lying positions. Look for the vitals as it is seen, and then adrenaline or epinephrine is the drug of choice. And if the source is there, we have to remove the source. Adrenaline has to be given in with the dose of 0.3 to 0.5 milligram, and it has to be given IM. Maybe in the important site is in the gluteal lateral aspect of the thigh or in any other region, but it has to be given IM for the better response.
But when we look at in the hospital settings, it's a usual response of the clinician that they also try to inject the patient or load the patient with steroid. Right. Yes. And we know that the steroid onset of action of steroid is approximately 6 to 7 hours.
Correct.
Right. So it has got no immediate benefit in treating anaphylaxis.
Yes.
Would you still prefer that after the patient has an anaphylaxis, you have managed the patient with IM, epinephrine, and adrenaline? Would you still prefer to load the patient with steroid?
So we have to wait for some time. We have to check the vitals if the blood pressure is coming down to normal or it is still not responsive. But because there is anaphylaxis reaction, some antihistaminic we have to give along with the steroid we can give, because it has got some anti-inflammatory effect also, and it also helps in the other anti-inflammatory reactions also. So we can always
to
use
prevent the
steroids. Yes.
to prevent the
Besides, there
late
is, yes,
manifestation of
correct.
anaphylaxis.
Yes, there is sometimes
Yes.
late response of the anaphylaxis also. There may be immediate effect and there may be some delayed response. So if for
Late
delayed,
effect, right.
definitely it is very helpful.
Right.
And
And any role of antihistaminics?
yes, antihistaminic has to be given. It has to be given either intramuscularly or IV, which is there, and definitely it
No,
helps.
I mean this second generation antihistaminic H1 blocker like
Yes, it does help.
third generation loratadine, cetirizine.
Injectables are there, but what for the injectables we have to start with. Even other drugs are helpful, but the problem is sometimes it is not available in all the setup with injectables, cetirizine, other things. So we have to give with the injectable antihistaminics, and along with that steroids, and yes, epinephrine. At least two doses of the epinephrine has to be given, and we will wait for the response. Most of the time, patient responds very well. If it is not, then we have to.
What is the observation time after first dose of epinephrine? How long would you like to wait before giving the second dose?
5 minutes, at least 5 to 10 minutes, we have to see and check the vitals, and immediately.
Usual response time is 20 minutes, I guess.
But
And yeah.
Okay.
And when do you call it a refractory anaphylaxis?
Refractory anaphylaxis is the conditions when the patient does not respond to the 2 doses of the epinephrine with the gap of 15 to 20 minutes, as you said. So we think that its patient is not responding, and so it's a type of refractory anaphylaxis. Right. At least 2 doses has to be given.
Taking from here, I'd like to ask Dr. Mohan Venkatesh. You told us that in one of the surgical procedure, you do a sponge with betadine wash as an helminthicidal or proctocidal agent, with using betadine as a proctocidal agent, right?
Yes.
Yeah. So as far as I have gone through the literature, when particularly they are doing the pair procedure for liver, or extended pair procedure for the liver, or for the non-pair with a large bore catheter, the best proctocidal agent is still hypertonic saline.
Yeah.
They give it for 20%.
See, there are so many cholesterol agents that are actually used. If you see from the starting period, the most commonly used is hypertonic saline and the betadine. I agree that in liver hydatid cysts, the hypertonic saline is most commonly used, because if you inject betadine into the hydatid cyst and there is a possible communication with the biliary tree, actually there will be the patient will develop cholangitis after that. That's why the most of the people will use the hypertonic saline in the liver. But as convention, you can use hypertonic saline in the lung also. But we use betadine in many of the procedures, not only this in thoracic surgeries. That's why we conventionally use betadine. So the percentage is 10% betadine that we use. So that the reason why betadine is not used this in liver is that we use the cholangitis in those.
And with the use of betadine, you basically put the let's say half an hour is the procedure time. You have all 10% betadine was soaked in the pleural cavity.
Yeah.
If in case the surgery fails, don't you think that the betadine-induced pleurodosis will be more difficult to manage?
See, we have a different kind of, the pleurodosis. If you are talking about the pleurodosis, the betadine is actually a least potent pleurodosic agent. So, I agree that many of the, the pulmonologists use betadine as a pleurodosing agent. But in our order of priority, betadine actually comes as a least potent pleurodosing agent. But that pleurodesis, that betadine what causes, is not a much concern in this situation, because our main intention at that point of time is to prevent any contamination, and if there is minimal contamination, we have to kill those colices. That's it.
And in your post-operative patients where you use betadine,
Yeah.
what was the incidence of chemical pneumonitis or organizing pneumonia because of betadine? Because the cyst is still open.
No, I have seen none. Till now, in our experience, we have seen none. Probably, as far as the pleurodesis by betadine is concerned, I may be biased because we see all the failures. So if there are 100 betadine pleurodesis are done, maybe 90% it may act. I don't know, but in 5-10% it doesn't act. Only those 5-10% come to us. So in that aspect, I may be biased, but we haven't encountered any kind of pneumonitis or such kind of things in betadine, because if you see 100 of our cases, in 40 to 50% of cases, in most of the infective cases also, we actually thoroughly lavage the pleural cavity with the betadine. In none of the cases it actually doesn't happen. And as far as this anaphylaxis is also concerned, the incidence is very, 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 very rare. We operated more than 150 to 200 hydatid cysts in the last 4 to 5 years. But it's very rare to have such kind of situation. But yes, if it happens, then everyone should be ready to tackle that situation.
So, taking further to the next section, I'd like to ask Dr. Umesh. Dr. Mohan Venkatesh has already given a beautiful talk on the surgical aspect. But as far as the non-surgical aspect is concerned, do you find any role of combination of praziquantel and albendazole in the treatment of hydatid?
Good evening, everyone. First of all, I'm really happy to be part of this webinar. Thanks to CCI for giving me this opportunity. So, coming to your question, there have been a few case reports where they have used albendazole in combination with praziquantel, but they have not found any benefit as such compared to albendazole alone. And the other instance where they have used the combination is after pair. So once they have done the pair procedure, and then they have used albendazole with praziquantel following pair. In this praziquantel, they have used only for 7 days, and then they have continued with albendazole for the remaining duration of 1 month. So currently, I feel there is still not enough evidence that we should consider both. We should simply go with albendazole, which is the most preferred agent right now.
Yes, true. And for lung, as Dr. Mohan said, that the definitive therapy is surgery, right?
Definitely.
So, how long before surgery you will prefer to give albendazole, and how long after surgery you'll prefer to give albendazole?
So before surgery, first of all, it depends on which echinococcus it is, whether it is echinococcus granulosa, which we commonly see, or the echinococcus alveolaris, which we rarely see. But straightforward, again, it depends on the classification, which type of cyst it is, based on the Garbi classification, whether it is a simple cyst, the C1 stage, or whether it is the C2 or the C3B or C3A. So it depends on that. Anyway, if it is a simple cyst which has this around 5 centimeters, then we start albendazole 1 week prior to surgery, and we give it for around 1 month. And after 1 month of albendazole therapy, we can recheck the titers. We have done a baseline serology, we can recheck the titers. So if there is still a rising titer, then we should considering to continue albendazole for around 3 months, and then again check the titers. See, usually we give albendazole therapy for around 3 to 6 months. So really, there is no fixed time. At least the duration, we cannot give a fixed duration after the surgery. It's more or less based on the titers and also the radiological, whether there is any recurrence or not. But yeah, I would say that around 1 month.
But prior to surgery, 1 week or a month?
1
So
week is
prior to surgery, when we knew, because sorry, Dr. Mohan, but whenever as a physician we sought for a surgical opinion, the first answer we get is, okay, we can operate in tomorrow or day after tomorrow. Right. So how long we need to give albendazole before we subject the patient to surgery
See,
on an average?
yeah, see, the actually we have to differentiate here the management of pulmonary hydatid with the liver hydatid. So broadly,
I think we have restricted ourselves to pulmonary.
what I'm saying is broadly the management actually differs in the two. In liver hydatids, it is a it's a protocol to give the preoperative albendazole and then you can submit the patient for the surgery. In pulmonary hydatids, actually there is no, if you see the data, there is no strong recommendation to start the albendazole therapy before the surgery. And yes, as I said in the presentation, depending on the intraoperative spillage, the completeness of the surgery, you have to continue the albendazole therapy post-operatively. So preferably although it is not a strong recommendation, but preferably in our scenario, what you will use is give 7 to 10 days of albendazole, do the surgery, and then give 1 month post-operatively if completely removed. If there is contamination or there is incomplete surgery, you continue for 3 to 6 months. That's the usual protocol that most of the surgeons in India that follow.
WHO says that a month of adjuvant therapy with albendazole prior to surgery.
Yeah, in adjuvant or neoadjuvant? I mean, before or after?
Neoadjuvant. Because albendazole has been shown to reduce the number of cysts, it has been shown to break it has been shown to soften the layers and all by almost 60 to 70%. So still there are different school of thought. Some prefer about a week, some says about a month. So it ranges from a week to a month prior to surgery.
You can say 1 to 4.
Umesh, Dr. Umesh, you while answering the question on combination therapy, you said that after treatment we can follow up with the serology titer.
Yeah.
Right.
Yeah.
So is serology titer for the follow up very useful? And when do the serology titers become negative after treatment, or do they still remain positive?
Yeah, the serology titers, especially the IgG levels, they will always remain positive for quite a long period of time. So even after surgery, for the first, say, 3 to 4 weeks, there will still be a rise in the titers. Okay. But after that, that is only after 3 to 4 weeks after the surgery or even after the medical management, even after that, there will be a stagnation of the IgG levels and then only it will start decreasing. So, so it is not going to be.
So, means if we have to follow the patient with serology to look at how the surgeon has done their job. So, we need at least a month of albendazole before we jump for that. So the baseline IgG will always be positive for epinococcal. And if there is any further increase in IgG, then we can think of recurrence. So, how long do we need to follow the IgG level? Let's say for a year, for 2 years, how long we need to follow with IgG levels?
See, if it is for Echinococcus granulosa, then probably we need to follow it for 6 months, and then we need to see radiologically also. Okay, so whether there is any recurrence, we are not using serology alone. We are seeing clinical symptoms. We are using the radiology and seeing whether there has been any recurrence of any cyst, whether any other organ involvement is there. So,
but the cyst grows so slowly, about a centimeter in a year, that radiology follow-up versus serological follow-up. Means radiology will take long time. That's why there's usual follow-up with serology.
Yeah.
So usually I think in case of granulosis, Echinococcus granulosis, they says that if the IgG level remains stable for a year or two, then it's almost a safe zone. You have entered a safe zone. As you said, 6 months to a year, so it has almost entered a safe zone if you do it further. Year follow-up. Dr. Arun, we have discussed all this thing, but I think we missed on one point about the lung cyst. Uh, if we have a lung cyst, which is complete lung cyst, which is not broken down, if we don't see any water lily sign, or if the patient is not having any complaints of ruptured cyst. So, how will you differentiate whether it is a hydatid also? Basically, mean to say what all can be the differential diagnosis of lung hydatid or cystic lung?
Yeah. Uh, Before commenting, shall I add a few points for the serology for the
Yeah,
previous
sure.
question? So, actually, for the text or in any literature, they never said that we need to follow the serology after surgery. If the surgeon is having, means they said that the complete evacuation has been done and there is no spillage, and followed by you can just give the albendazole as you rightly said for 1 to 3 months. There is no fixed regime actually. It all depends upon the surgeon, and they need to say that the complete evacuation is done and there is even not even a slightest chance of some spillage is there. And the serum antigenic assays have come to role in this play. That antigen, if it is detected, that means it is active infection, recent infection or active infection, which usually tends to become negative after surgery or after complete eradication by the treatment also, but not the serology, which we have that IgG, which tends to, there is, it's erratic. Sometimes it may be high, it may be persistent. So there is no role of following the IgG levels after surgery or after or during treatment. That point I just want to add on. But unfortunately, we don't have that antigenic assays and all in India. I think in part of country. And coming to the particular question about the differential diagnosis, to the viewers, I will just say that what we are talking about, the cyst means it is fluidic. But if you take in the radiological lung cyst means it is translucent. So the differential diagnosis of what we talking today is a what is a fluidic, or it is a rounded hypodense opacity or a rounded opacity. If it is a uncomplicated cyst without any rupture, then the differential diagnosis would come as a bronchogenic cyst or even a bronchocele or a contained abscess or even sometimes a peripheral bulla which has gone into an infection. These are all the differential diagnosis which comes for a rounded, well-defined opacity. Sometimes even a old granuloma if the size is small, or even a hematoma or a aspergilloma with absence of a crescent sign. So it is actually a differential diagnosis based on the size of the opacity what we are seeing in the X-ray or the CT, and then the differential diagnosis should be kept. So the X-ray, the differential diagnosis is different, but if you take on the CT scan, it is very easy to define with even a non-contrast CT based on the HU units, whether it is just a solidified mass or it is a fluidic. Then we can narrow down the diagnosis, and if an additional cyst in the liver, especially with a peripheral rim of calcification in the liver, or with the multiple daughter cyst is there, then definitely in the CT scan,
And it becomes easy.
then it becomes definitely the hydatid cyst. So,
But still,
yes, the calcification is very rare in pulmonary cyst as compared to the hepatic cyst. So the differential diagnosis will actually come for the X-ray based on the size of the opacity, contour of the opacity. Then we can we carry on with many diagnoses as a differential one. This is for an uncomplicated simple cyst.
yeah, yeah. So uncomplicated, simple cyst in atypical locations, they are usually very difficult to say on the basis of radiology alone. If it
Yes.
is a simple cyst, once it becomes complicated, then definitely we have multiple signs and stages to define
Yes.
it. But a simple cyst on a atypical location, left upper lobe or left lower lobe without any liver involvement, then they are really, or right upper lobe, isolated right upper lobe. So these are the atypical sites which can usually are difficult to diagnose.
Because this
So
is
I
usually in
think,
the lower lobe, so we have to keep even
yeah,
a differential diagnosis of AV aneurysm. So sometimes AV
even
aneurysm,
reason,
huge one,
right,
can also be present as a lower lobe, a soft density mass.
right. So I think we are done with the panel discussion, and if everyone agrees, we can open the house to Q&A session from our enthusiast audience.
Just I wanted to add one thing here.
Yeah.
The follow-up, sometimes the radiological picture is misleading. So a large cyst in one of the lobe, actually the surgeon usually does the complete job. As I said, it's not a complete cystectomy. It is just a cystostomy and the removal of the contents. Sometimes what happens is after 2 months or 3 months, the lung actually adhered to the surrounding structures. And once you get a CT, it again appears that there is a cyst formation in the liver. But actually, it is a residual space rather than a recurrence of the cyst. In most of the situations, many of situations
Yeah.
it happens. So it is very important to be in coordination with the surgeon to actually, is it recurrence or is it just a residual space? That's the most important that we have to follow.
Yeah.
I also
So
just wanted to add something. Hello.
yeah,
Yeah, I just
yeah,
wanted
yeah.
to say about that nowadays there is large bore aspiration is also being done. Like we have intervention
Right.
radiologists,
Non-pair technique.
yeah,
Yeah.
who are the pair technique is very rarely done in case of lung hydrated cyst, but large bore
Yes.
aspiration certainly done by our intervention radiologists nowadays, and there is very less risk of spillage. And the advantage is that we are able to aspirate the fluid, and if we send this fluid for serology, there is a much higher chance that we'll get it positive. So it almost
Right.
like clinches the diagnosis, even if we have a doubtful radiology or something. So this is
So
one
there are
thing.
interventional methods of
Yes,
diagnosing rather than the non-interventional method. We do have
yes,
interventional methods, right?
yes, yes.
Right.
Okay.
Sir,
Okay.
can I?
So we have got few
One
questions.
second.
Yeah.
One second.
I think.
Can I add one thing? 1 minute.
Yeah.
Yeah, actually, when we are talking about the earlier involvement of the hypersensitivity reactions, or what we call it anaphylaxis, one important thing, as I was talking about, and you asked that if the patient does not respond to the early or refractory anaphylaxis, then one has to see that whether patient is on any other drugs or not. Whether patient is taking, history is very important, whether for the medical point of view, whether patient is on beta 2 antagonist or not, he is taking beta blockers or not, whether he is taking any AC inhibitors or not, or whether because of the pain or
Right.
other things, he is taking chronically using NSAID. So for these things, one has to take care of and asking the proper history and then to
Very
go
right.
on the another route. So glucagon and other drugs may be used, but though they are rarely used, but it is important that they can be used if the patient is refractory, and so proper history is very important. Anything, right,
Yeah.
sir?
Right. Thank you. Thank you. So I'm taking up the questions with the audience. So there's a Mr. Dr. Said Kumar Das from West Bengal. How to manage hydrated cyst in the lungs, which occurs after medical therapy. So I think Dr. Mohan, would you like to take the question?
Yeah, sure. See, the primary management of lung hydrated, most of the situation, 90% of situation it is surgical. See, we often confuse with, we think that medical treatment is an alternative to the surgery. In 90% of cases, it's not. Medical therapy is only selectively used in cases of very, very small hydratates, very limited in number, not causing much problem to the patient, or the patient, or other extreme, the patient is not fit for the surgery, or it's a disseminated condition. So, which contribute maybe about 10% of all the cases. In rest of the 90% of the cases, the primary treatment of hydatid is surgical with
Right.
the helminthic drugs before and after the surgery. So the management of hydatid is once you diagnose it as hydatid by the way that has been discussion happened, you start the anti-helminthic drugs. After 10 days or so, you send the patient to a surgeon. He will do a complete job, and after that, you can go give the anti-helminthic for 1 month, and then you are done with the patient.
So there's another question from Dr. Jiten Dayal, Gujarat. Dose and duration of albendazole and side effect of drug. So basically, it's a 15 milligram per kg of albendazole divided in 2 doses. And then there are few patients in which we cannot use albendazole, for example, pregnant patient or in chronic liver disease. There you can have an option of albendazole, which is be given in 40 to 50 milligram per kg in 3 divided doses. And he has asked about the side effects. So except for the minor transaminitis, no major side effect. It might have some delayed manifestation of bone marrow suppression. Nothing much immediate side effects. Transaminitis is basically the one which has to be looked into. Dr. Manglesh from Madhya Pradesh, Indore, he has asked a good question. The pulmonary hydatid with cardiac hydatid cyst, post-operative cardiac cyst removal, till how much time we have to give albendazole? Okay, Dr. Manglesh, too, I think we have discussed this. And the optimal duration post-operative is not clear, but as Dr. Mohan already pointed out, if it is complicated cyst, if it is involving more than one serous cavity or disseminated, post-operative you can give up to 6 months. Dr. Jairam from Tamil Nadu, any role of Cassoni test in diagnosis of hydatid? So I have no clue to the Cassoni test, what it is. But Dr. Umesh, do you have any clue to it?
No, it's the intradermal. It's of historical importance. It's the intradermal test that was done to check hypersensitivity before. But nowadays we are not doing, because as we have much more better test to diagnose hydatid. We have serology and such things. So this Cassoni test itself can precipitate a hypersensitivity anaphylactic reaction. So it is basically an intradermal test that we are doing. So no role right now. It's just of historical importance.
Sir, apart from that, Cassoni has got no specificity. Actually, sensitivity and specificity is very less. That is why it is abandoned now, not used. Earlier it was used, but nowadays it is stopped. Nobody is using it.
There's one more question from Dr. Vigyan Kumar Jaina, Bhubaneswar. How to differentiate hydatid cyst of lung and pleural effusion? I think the question is not very clear. You want to differentiate a cyst with effusion, it is quite an easy. You want to differentiate a ruptured hydatid cyst leading to pleural effusion from non-hydatid pleural effusion. It has got its own radiological manifestation. So I don't think there is any more questions.
I think we should ask something to Dr. Roy.
Yeah. I think on taking the question with the audience, Dr. Roy, we all know that there is very limited role of lung transplant in hydatid per se. There is no as such literature which says that there's a role of transplant in lung hydatid. But when I was giving my presentation, I told that about 1% of the cases of Echinococcus alveolaris have an extrahepatic manifestation. And Echinococcus alveolaris, they grow both within the cyst and outside the cyst into the lung parenchyma or liver parenchyma. So, do you find there might be a role in that small 1% of extrahepatic, particularly involving the lung? And in my case, which has got this bilateral extensive hydatid disease, though I don't have a follow-up because it was a very old case from my senior residency days. So I don't know the follow-up of the patient. But do you think that this case where there's so much extensive bilateral hydatid, we cannot go and remove each and every segment, but virtually we can end up with a bilateral pneumonectomy? Dr. Soumitra? Are you there?
Hi. Yeah. Can you hear me? Yeah. Hi. So first of all, good evening to all my good friends of CCI all over the country. And I believe more than 1,000 has logged in, which is a fantastic feat.
Great.
Yeah. And thanks again to my good friends in CCI who has invited me to be joining you people here. Well, your question, as you said, there is extremely rare possibility or role of transplant in hydatid cyst. Actually, before coming and joining you people, I was going through Google Scholar. Has there been any reported case history also
and I found there is nil. In your case, I found that that's really interesting. They are studied with cyst bilaterally and so much of affection. I don't know how was the lung function, but as you said, yes, the alveolar version is actually grows outside the cyst and into the alveoli. So, in a very, very far-fetched way, if really the things are bad and the lung alveoli and the lung function has become, I would say, permanently damaged so much that he is oxygen dependent in just like a case of a say ILD kind of thing, where the patient is already an oxygen dependent and there is no possibility of surgery perhaps because of his lung function is so poor. In those kind of very far-fetched cases with a high risk of death, perhaps more than 50% chance of death due to the lung disease within the next 2 years, if transplant is not performed, perhaps they will fit into a transplant. But to give a one-line answer, no.
This was the case, as I told you, it was very long, it was a long back
Yeah.
when in my senior residency, and at that time I remember lung transplant was a fancy thing which happens only in US. So had it been that we never thought of subjecting the patient or having a second opinion of a lung transplant surgeon. So that could be a first case having lung transplant in a hydatid cyst.
Yes, we could have got that distinction of transplanting.
Right.
Yeah.
Yeah.
But the point here is again the surgery is the only kind of therapy, but also medical therapy is not so bad if it is a small disease or a few cases, only a few small cysts. Actually, when I was a PG, we have published a case, actually a case record that with the standard therapy of albendazole for 6 months, in one of our case, actually the cysts has gone down so much it is almost not visible in the X-ray. Only in a CT scan we could find it out. So yes, there is minimal but focal role of drugs, obviously, but surgery is the mainstay of therapy. Yeah, and the surgeon has to be extremely cautious so that it does not spill out. That is also one of the big important things.
We will be, sir.
So there's another question from Dr. Tirdeep Chatterjee, Maharashtra. If you have lung hydatid cyst and there is additional liver involvement, then along lung surgery, do you do anything for the liver lesion? Lung plus liver. So Doctor, before handing to this question to Dr. Mohan, is very excited to answer it. Dr. Tirdeep, I think. Okay, so the lung involvement in presence of liver cyst and liver involvement in presence of lung hydatid. So primarily lung hydatid. So there's about approximately 20% that primary lung hydatid will also have a liver cyst. And as Dr. Mohan has already pointed out that definitive therapy for lung is surgery. Now coming to the liver, we haven't touched the topic on liver hydatid. But there is staging system which has been laid down by the WHO, and the treatment is being guided as per the staging system. Over to you, Dr. Mohan.
Thank you. See, I think we can go ahead with this lung hydatid and liver hydatid in a same go. So we had probably about 30 cases or so where we have right-sided lung hydatid or left-side lung hydatid with a large liver hydatid. So, but the order of the priority, as I said, it goes to the lung first. So you have to operate the lung first, and then you can go ahead with the liver. So the approach to liver can be, nowadays we are doing with laparoscopy, or sometimes if it is so large, you can do a laparotomy and you can proceed. And sometimes where the lesion is actually located at the superiormost extent of the liver, which is involving the diaphragm, from the right side also, you can create a hole in the diaphragm and you can manage the liver cyst transdiaphragmatically also. So the answer is you can manage both the thing in same sitting in most of the cases.
In the same way.
Yes.
Any other question we have from the audience? I can't see any more questions.
I shall ask Dr. Soumitra Rai. Shall
Yes,
I?
sir.
Yeah.
Yes, sir. Go ahead, please.
Yeah. So recently, sir, we had one patient from Tajikistan. He had a huge hepatic hydatid cyst, but then they have done liver transplantation. I don't know why. And after that explanted liver, they have found hydatid cyst. They gave albendazole for 3 months and stopped. Exactly after 1 year, he had collapsed and he fell down. And then they found some cyst in the brain, and incidentally also found to have 3 or 4 multiple cysts in the lungs. So he came to us. So what is your take on this post immunosuppression? So what will happen? How long the albendazole therapy should be given? Anything?
Very, very, very interesting question. Perhaps we do not have a one-line answer. Though standard textbook says about 6 months post surgery is the maximum kind of a therapy. But in your case, obviously, the immunosuppressant had made such a huge impact in that patient with multiple area. The cysts have gone in the brain and lung. We really don't know. Perhaps we have to think of in that kind of a case, just like we give Septran lifelong in a post-transplant case. Perhaps is there a role for that, or we don't know? It's still we are learning. Perhaps a year or perhaps 2 years. From now onwards, I will keep my antenna up. Really, if that kind of a scenario happens, I would perhaps then think of giving it up to 2 years, just like that I am thinking now. And maybe we will recheck the serology often.
Yeah. So, Dr. Arun, was the specimen identification, species identification was done, was it in alveolar echinococcus or granulosis?
The granulosis they have identified, but surprisingly,
They have identified granulosis.
Yes, but they are given only for 3 months. Intense immunosuppression was there, and then they stopped because there was. They thought that there is nothing else, so they stopped. But the question is, nobody knows. Nobody knows
So
whether the
basically,
patient will get
post-transplantation, the usual recommendation in alveolar, it is not in cystic, but for whatsoever reason they have transplanted. But for post-transplant, the minimum therapy duration is 2 years. And they stopped it after 3 months. So minimum duration therapy is 2 years. And whenever we see the infection paradigm in the solid organ transplant, so the most unusual pathogens they occurs in the first 6 to 9 months, and after on this is a common infection which occurs. So for hydatid, it is 2 years is the usual therapy which is recommended in alveolars.
Yeah, understood.
And yeah,
But
so
it was a
sometimes
granulosis. We hardly see in our settings usually. Say about TB, NTM kind of a disease. If say it is an NTM lung and we have done the lung transplant post-surgery, post-transplant, we give about 3 months of NTM therapy. So perhaps the surgeon and the physician there perhaps has got the same kind of thinking, like 3 months is good enough.
Yeah, maybe. But NTM, it's means it's very slow going, and it sometimes I think means it is completely different pathophysiology of NTM. We can't compare NTM to the hydatid, right?
We cannot
So it is more pathogenic potential than the NTM. So recommendation post lung transplant, post liver transplant is 2 years, minimum 2 years of albendazole.
That's what I said. 2 years we should have given.
2 years. That's what he said. Yeah.
Even for normal surgery,
Occurrence of
the literature says up to 7% relapse rate, even for normal surgery.
Yeah.
Yes. So you need to keep a follow-up.
Question from Dr. Manju from Maharashtra. Occurrence of brain hydatid cyst, how often? So Dr. Manju, these are all rare side. We can have on brain, we can have on bone, and we can have cardiac. So they are all very extremely rare sites. So incidence may vary depending on the immunity of the patient, immunity on the granuloses versus alveolaris. So it is no clear data from India that what is the incidence. But yes, one thing which I like to say is it is difficult to diagnose brain hydatid because we saw that the IgG serology in lung is approximately 60 to 65%. Even it is very less or very less in brain, right? So if you're suspecting a brain hydatid, then serology is not going to help you. That's the only comment I can make on your question. If anybody has any answer to the question that what is the incidence of brain hydatid?
All I can say is it's very rare. Like
It's very rare,
yeah, like liver followed by lung. Lung itself is only 20 to 25% incidence. Most
because
commonly is liver.
brain,
And
brain,
certainly not going to
ophthalmic
be in our
hydatid,
list of differentials. We are easily going to miss
yeah,
if it's only going to happen
sure.
in the brain.
And the reason, Dr. Manju, they don't, IgG serology is not positive because there are, I think, there's this brain hydatid, then there's a spleen hydatid, and then there's ophthalmic hydatid. So BAC, brain, spleen, and ophthalmic, they don't produce antibody. So the serology will never be a positive. So diagnosing them, it's a difficult task and probably neurosurgeon's task.
Yeah, the occurrence must be around 1% or less than that, perhaps. But obviously, it can cause as well like feature with raised intracranial pressure and focal neurological deficit.
It all depends upon the endemicity of the disease also. If there is in some area, if it is there, maybe we'll get more percentage of the cases incident wise. But yes, in our country, of course, the rate is also less incidence of the hydatid disease as such compared to the other areas in the Europe and other countries. So maybe that is one of the features we are getting less number of the cases. And as Dr. Girish said, yes, they don't produce the antibody or the serology is also not very helpful. So maybe that. Okay.
So I think there are no more questions from the audience, and I'd again like to thank the team CCI technical team, my all esteemed panelists, and the audience for taking out the time and putting up some difficult to answer questions. And if there is any further question and answer, I think we are ready to answer, or we can just call it off. Okay, so since we don't have any question, I think we should call it off. Good night to all of my seniors, to my colleagues, and to all the audience. Thanks a lot. Thanks again.
Thank you very much.
Thank you.
Thank you. Thanks. It was a good
Thank you very
discussion.
much.
Take